Hello and welcome to another episode of the Root of the Science podcast with your girl, Anne with an E. And today, Teresa, our show producer, will be joining me as a co-host in this first episode of the Polio Eradication series in Nigeria. Welcome, Teresa.
Thank you so much, Anne. The Polio Eradication series has a total of 4 stories, 2 podcast episodes, and 2 articles. And this is the first story in the series and the first of the 2 podcast episodes.
Polio eradication in northern Nigeria has been a challenge due to various social, cultural, logistical, and security issues. Despite this, Nigeria celebrated a key milestone in polio eradication when, in 2020, it was declared wild polio free. However, in 2021, Nigeria recorded cases of vaccine-derived poliovirus. Due to this outbreak, routine immunization efforts have been intensified, especially in northern Nigeria where polio is prevalent. The Core Group Polio Project has been instrumental in addressing these challenges with routine immunization through innovative strategies and community engagement. By working closely with traditional and religious leaders and volunteer community engagement mobilizers, the Core Group Polio Project aims to tackle vaccine misinformation, foster trust and acceptance of vaccine programs in northern Nigeria.
Dr. Samuel Usman is a public health expert who has served as the Secretariat Director for the Core Group Polio Project in Nigeria for 10 years. He has a wealth of experience in managing and implementing health programs and has played an important role in the fight against polio in Nigeria. In the first part of our interview with Dr. Samuel Usman, he will explain the fundamentals of polio, like what polio is, what it does to the body, and the mechanisms of the polio vaccine. He will also provide an overview of the Core Group Polio projects in Nigeria, highlighting the significant strides made in polio eradication and what his role as the Secretariat Director for the last 10 years was all about and what position he currently holds.
Good morning, Dr. Samuel. Welcome to the show.
Good morning. It's my pleasure to be on the show.
It is such a pleasure. Today, I'm joined by Teresa, my co-host. So welcome, Teresa. Welcome to the show as well.
Thank you so much, Anne. I'm happy to be co-hosting with you today. Thank you.
Fantastic. So let's get things started. So Dr. Samuel, like we said, you've been part of the projects in terms of polio eradication in Nigeria over the past couple of years. So for some of the audience who might not be familiar, can you please explain how the polio virus actually affects the child and how some of the vaccines actually helps preventing the occurrence of polio purposes?
Thank you very much, Anne. The polio virus actually, of course, like we know, viruses are tiny, very, very tiny microorganisms that you cannot see with your naked eye. And that's why you cannot see them as they move around the environment. So when these viruses, because they're everywhere, they're in the stool, they're on the floor, they're on the ground. Typically, when children play on the floor, because the virus is found in the stool, they touch a stool, because they are kids, they're playing on the floor, they may not even see the stool particle. Any fleck of stool contains a virus. So as they play and they use their hand without washing their hand and they touch their mouth or through the nose, the virus gets into the system. And when it gets into the system, the virus is very, very smart. It passes from the mouth, it goes to the area around the mouth and the throat. It's called the oropharynx, the oropharyngeal area. And then it goes down to the stomach. Now, from the time it is in the oropharyngeal area, it begins to penetrate from the blood into the body. And because it has a predilection or a predisposition or a likeness for what you call the lymphoid tissues. The lymphoid tissues are a cluster of cells that are part of the immune system. And these cells are distributed in strategic parts of the body. Now, the lymphoid cells, there are some around the neck area, which of course is close to the throat. So as the virus gets into the throat, some of them quickly penetrate and go to the cervical lymph nodes. That's the lymphoid tissues around the neck. Then as the virus is going down, it keeps multiplying very fast. By the time it gets to the abdomen or to the stomach, it goes to the mesenteric lymph nodes, which are another group of lymphatic tissue that are around the stomach area. And from there, from the lymphoid tissues, because they are linked to the spinal cord, it infects the spinal cord and the brain stem cell.
Sure.
And because the spinal cord links the brain with the limbs, because of course it is the brain that controls the workings of the limbs, it destroys the anterior horn cells of the spinal cord. And when it destroys the anterior horn cells of the spinal cord and the brain stem cells, it causes paralysis. Now, depending on where the damage is more at, it can either be an upper limb paralysis or a lower limb paralysis. That is the two legs or the two arms, or one leg, one arm, or both legs. So depending on the damage, it causes paralysis. Put very simply, that is how the poliovirus causes paralysis, by damaging the spinal cord and part of the brain.
Interesting. Thank you so much for that insight. It sounds very catastrophic to the body, actually, and especially in a child. It must be even more devastating because I'm sure they don't even understand what's happening to them. Where one minute they were just playing, and the next, this happens. So, given that overview of what actually this virus is, take us through how then the vaccine helps mitigate all of these side effects that actually happen to the child's body.
I would start by saying that the polio vaccine, I will call one of the wonders of modern science. If you recall, around about the year 1980, around 1981, 82, 83, before the Polio Eradication Initiative, the Global Polio Eradication Initiative was started in 1988, about 350,000 children were being paralyzed globally.
Sure.
So the vaccine is a big success story. Now, the oral polio vaccine that the child takes, there are 2 drops, serves to stimulate the body's immune system when it gets to the blood to produce antibodies. That is, some soldiers that are within the body. The soldiers lie dormant. When a foreign body, like a virus or a bacteria, in this case the poliovirus, gets into the body, if the body's defenses are not strong, what happened that I explained before happens. That is, it goes to the lymphoid tissue and damages the anterior horn cells of the spinal cord or the brain stem cells, leading to paralysis. So, what the polio antigen does is the polio vaccine contains antigens to the 3 types of poliovirus. There are 3 types of polioviruses: type 1, type 2, type 3. So the poliovirus has 3 types. Now, what happens is that the polio vaccine has 3 types of the virus, but in a very little quantity that will not cause paralysis. The reason for that is that little quantity is to stimulate the body's immune system so that it appears as though it is the real virus, but it's not the real virus. It is a little quantity. That little quantity is to stimulate the body to produce an antibody. Now, those antibodies, when they are produced, they remain in the body. Because the amount of virus in the vaccine is very little, it doesn't cause paralysis. but it has already stimulated the body to produce antibodies, which is called humoral or serum immunity. What happens is that when the child is now exposed to the real virus, by then the body has already produced these antibodies that are already in the blood. So these antibodies will prevent the virus from causing paralysis by attacking the virus. And what happens is that because when you take the vaccine orally, the gastrointestinal tract or the stomach, by the time the vaccine gets to the stomach, the viruses replicate the vaccines in the little viral particles in the vaccine multiply very quickly so that they flow into the body far and wide so as to give maximal protection to the body, because antibodies are already everywhere. They are already awake. They've already been stimulated by that little viral particle that was contained in the vaccine. So because that viral particle has stimulated the body's antibodies and they're out there everywhere, by the time the real virus comes in, whether it is type 1 or type 2 or type 3, the antibodies that are already in the bloodstream swallow those viruses and destroy them. So what that means is that by the time the real virus comes in, the body is already protected. And the more you continue to give the vaccine, the more you are stimulating the body to produce more antibodies. That's why we continue to give the child the oral polio vaccine regularly. You give it either at the facility or during campaigns.
Thank you so much. Wow. Like you rightfully said, a true modern wonder to medicine. Teresa, over to you.
Okay. Thank you so much. That is a very, very elaborate explanation. So, Dr. Samuel, currently you are the Secretariat Director of the Co-Group Partners Project. So, what exactly does this organization work on in Nigeria, and what are some of your key roles as the Secretariat Director?
Thank you very much, Teresa. Permit me to start by saying that I'm no longer the Secretariat Director.
Okay.
I got promoted to a senior role in the Global Core Group Partners Project. So I'm now the Global Senior Technical Advisor supporting the global program. We work in 11 countries. So I provide support to the 11 countries. But prior to December 18th, 2023, I was the Secretariat Director. I started the program in Nigeria and I managed the program for almost 10 years. And by the grace of God, I got elevated to a bigger position. Having said that, I will say that, the role of the Secretary Director, which I was privileged to occupy for almost 10 years, of course, I know the role very, very well. The Secretary Director is actually the overall lead and manager of the program in Nigeria. The polio program in Nigeria is very well structured. I tell people that it is clinically and again, militarily structured in the sense that everything is well arranged and well coordinated. So we have what is called the National Polio Emergency Operations Center, what we call the EOC for short. Now, the EOC coordinates the entire polio program in Nigeria. And the EOC is managed, of course, by government of Nigeria. It is housed within the National Primary Healthcare Development Agency, which is the agency under the Ministry of Health, under our Federal Ministry of Health, that oversees all primary healthcare interventions. Now, the EOC, the Polio EOC is housed within MPCT, which is an arm of our Federal Ministry of Health. Now, in that national EOC, there's who you call the incident manager, who is a government appointee and oversees the EOC. The EOC consists of all partners. There's what we call the GPI partner, that is WHO, CDC, UNICEF, the Bill and Melinda Gates Foundation, Rotary International. and of course, Gavi. Now, all of these partners, including CGPP. CGPP is also part of these partners that are within the national EOC. Then, at the state level, in all the polio high-risk states, you have what we call the State Emergency Operations Center, which is a baby of the national EOC. So the Secretariat Director is a representative of CGPP who sits in the National Polio EOC that coordinates the Polio Eradication Initiative in Nigeria. So by virtue of being Secretariat Director, you are part of the leadership of the polio program in Nigeria. So that's one of the most primary and paramount roles of the Secretariat Director, to sit on the National Polio EOC and work with the incident manager and other polio partners to coordinate and manage the polio eradication response in the country. Another important role that the Secretariat Director plays is that because through funding from United States Agency for International Development, we support polio eradication activities in 5 polio high-risk states, 3 in the Northwest, Kaduna, Katsina, Kano, and 2 in the Northeast, Borno and Yobe. Now, because Core Group Partners Project provides technical assistance and channels funding from USAID to its implementing partners, which is what we call the Secretariat model. I'll talk more about it later. The Secretariat model actually prioritizes capacity building of international NGOs who are giving funds to advance to the local NGOs, or what we call civil society organizations, who are in the communities, through whom we recruit volunteers in those communities to do house-to-house mobilization and carry out activities that will build trust and ensure that every child who is eligible for the oral polio vaccine, that is 0 to 59 months or 0 to 5 years, is vaccinated. So what that means is that the Secretariat Director ensures that all the partners in Nigeria who get USAID funding have the capacity and the human resources, well-trained human resource, to provide polio eradication services. So for instance, in Nigeria, there are 3 implementing partners. Catholic Relief Services, which oversees the work we do in Kaduna, in the Northwest, and Yobe in the Northeast. So they work in 1 Northwest state and 1 Northeast state. We have International Medical Corps, which oversees the CGPP work in 1 state in the Northwest, which is Kano, 1 state in the Northeast, which is Borno. So you see 4 states are gone. The last state, but of course not the least, is Katsina State. So Katsina State is implemented in the Northwest, is a Northwestern state, is implemented by Save the Children. So we have 3 partners in Nigeria. Catholic Relief Services overseeing 2 states, Kaduna and Yobe. International Medical Corps, or IMC, overseeing Kano and Borno. Then Save the Children overseeing Katsina. So these 3 partners, in those states where they oversee our work, they work with a civil society organization, a local NGO, which they pass the fund we give them to. And not just the funding, with the funding that USAID advances through us to them, they train these civil society organizations, who also in turn train the civil society organizations, the volunteers that are recruited at the community level. So the role of the Secretariat is to ensure that the Nigerian Secretariat is made up of technical persons, the Secretariat Director, technical persons who know about community mobilization, they know about how to communicate the importance of polio, they know how to do what we call active flaccid paralysis surveillance. So they build the capacity of the community volunteers at the community level through the civil society organization, so that these volunteers are able to go house to house with their flipbook, which contains important messages on polio awareness, the importance of the vaccine, what the vaccine does. It also has pictorials on how the virus is gotten from the stool, it gets to the mouth and it replicates, so that they know that hand washing is important, ensuring that children do not play in the sand is important, so that they know how to protect their babies and themselves, of course, from polio. So what that means is that the Secretariat Director oversees this entire ecosystem, if I will use that ecosystem of activities, of plans, of interventions that ensures that the community is well mobilized, because in polio, awareness is critical. As we raise awareness, that is not enough. We raise awareness to ensure that people build trust in the vaccine, because if they don't trust the vaccine, they won't allow their children to take it. So the secretariat director oversees the work plans, ensure that all the partner work plans are properly done. They contain activities that will indeed lead to proper mobilization of the households. The activities are properly budgeted for, because, like every donor, when they give you money, they want you to account for that money.
Yeah.
So the secretariat that is responsible for ensuring that when the partners collect that money, they manage the money well, they use the money for the activities for which they are planned, and importantly, the secretariat that ensures that those activities are tracked. And tracking those activities require what we call indicators, key performance indicators. And those indicators are indicators that the USAID, our donor, holds us to account for. If you say, for instance, ensuring that children 12 to 23 months are fully vaccinated with oral polio vaccine. Now we have to have the partners reporting regularly to show that indeed they collected this money, they implemented this activity, and these are the number of children that the activity enabled to be vaccinated. It is the responsibility of the secretary director to ensure that the activities, the work plans are properly done. The work plans capture activities that will ensure that the children are properly, the families and the children are properly mobilized, and that the children are vaccinated, and that the indicators are reported to monthly, quarterly, semi-annually, depending, and annually. So the role of secretary director is holistic to ensure that she or he manages the entire program technically and programmatically, ensuring that donor funds are properly managed, are properly accounted for, and activities that will lead to a proper mobilization of the communities to ensure that every child is vaccinated are implemented. And importantly, we have what we call acute flaccid paralysis surveillance, which we do at the community level. We call it community-based surveillance. That enables every child who has any form of paralysis to be detected, because that paralysis could be from polio. And we have studies that show that when you see one child with acute flaccid paralysis, it means at least 200 children have been infected. So we have a very strong surveillance system that is done by volunteers to ensure that any child with any form of paralysis is detected. So that community-based surveillance is also overseen by the secretary director to ensure that the partners are carrying out this community-based surveillance in a proper manner. Now, I must say that the secretary director doesn't do everything, because the secretariat model emphasizes giving at least 60 to 80% of the resources to the community. So we keep very little resources at the secretariat, while we give most of the resources to the partners to implement at the community level. That is the beauty of the secretariat model. So the secretariat director is the commander-in-chief of the secretariat model at the country level, if I will use that term.
Your previous role. So can we get something very, very little about what you do now after the promotion?
Thank you, Teresa. My current role is called Global Senior Technical Advisor, STA. The role of the STA is primarily to provide technical assistance across the countries where CGPP works. And this technical assistance, like the name implies, is to ensure that the technical interventions that will ensure and assure polio eradication are implemented in a qualitative manner. And it's important for me to state here that there are 4 pillars of polio eradication. These 4 pillars are a sine qua non, or a must to have in place before you can eradicate polio. And those 4 pillars are: number 1, strong routine immunization. That is immunization that is provided at the facility level. Number 2 is supplemental immunization activities. That is the campaigns that we do that takes the vaccine to the child at home. The routine immunization is at the facility level, while the campaign, the SIA, takes the vaccination to the child at the household level. So the campaign, or the SIA, is the second pillar. The first pillar is strong routine immunization. Second pillar is supplemental immunization activities. Third pillar is surveillance for acute flaccid paralysis. That is detecting any child 0 to 15 years who has any form of paralysis. That's the third pillar. The fourth pillar is outbreak response to any outbreak of polio. Now, the senior technical advisor is to ensure that across the global CGPP program, these 4 pillars are being implemented in a qualitative manner across all the countries where we work. That's number one. That's in terms of strategy.
Mm-hmm.
The second thing is that the senior technical advisor ensures that the content of the interventions are of good quality. For instance, in the community level, we have volunteers. These volunteers, they must know what we call the case definition of acute flaccid paralysis. Now, the case definition is what you see in order for you to say that this child has a paralysis or has paralysis that is likely to be that of polio. Now, we ensure that the content, the training curriculum of all the CGPP country programs are of good quality. We also ensure that the monitor and evaluation system, that is the data management system, is of good quality. Because if you don't have good data management system that properly tracks, properly monitors, properly analyzes data in a qualitative manner and reports that data in a qualitative manner, then you cannot succeed. Because polio is about numbers. If the numbers are inaccurate, then you cannot know how well you are succeeding or how well you are failing. You can be getting good numbers. Meanwhile, at the implementation level or at the community level, people are not being mobilized. Meanwhile, maybe out of 100,000 people, your data shows you that you've mobilized 98,000. That's 98%. But in truth and in fact, you only mobilize 20,000 because the data is false. The data is not of good quality. So one of the roles of the senior technical advisor, which is my role by the grace of God, is to ensure that our monitoring and evaluation system in all the countries where we work is of good quality. For instance, I support the Niger program. We started the Niger program in 2022, July. This is almost 2 years now. The program, we work in Ifa and Maradi regions of the Niger Republic, which have borders with Nigeria, because one of the strengths of CGPP is cross-border coordination. So I support them. I provide technical assistance, provide technical support. I was there sometime early this month to work with them on portfolio review. So my role is basically traveling to the various countries to provide technical assistance, technical support as may be needed, and ensure that the programs and interventions are in alignment with our goal. The goal of CGPP is to contribute to polio eradication by increasing population immunity and enhancing surveillance for acute flaccid paralysis. So my responsibility is to make sure that in all these countries, this goal is front and center, and that activities and plans are in line with achieving this goal, and that data management systems are of good quality to guarantee that the data that is being harvested or accumulated or aggregated from the community are of good quality, and that the volunteers and the program staff are receiving the requisite training that will enable them deliver proper services at the community level. Because training is key. Capacity building is key. If people don't know how to do the mobilization, they don't know how to gather the data, they don't know how to analyze the data, they don't even know how to define acute flaccid paralysis. How would they recognize acute flaccid paralysis? If they don't recognize the paralysis, how would they detect it? If they don't detect it, how do we assure that in that community there's no polio? If they don't go house to house to ensure that they mobilize the households, how do we build trust? The only way you can build trust is to continue to tell the households that this oral polio vaccine is useful, is beneficial. There are a lot of myths and misconceptions about polio. And those myths and misconceptions, sometimes they never go away. They can only be surprised. So we have to keep giving them the message so that they don't drop the ball. Because somebody can just enter the town and say, polio is not true, polio causes paralysis, and you've mobilized them before. They agreed. Somebody came and told them something different. So you have to keep going, if you see what I mean. Yeah, so my role currently is to support the global CGPP program and ensure that across all of our interventions, things are done in a qualitative manner along the 4 pillars of polio eradication that I mentioned a few minutes ago. And of course, if I would quickly add, we are not, because of the strength and the capacity we've built over the years, USAID has given us additional funds to do what we call global health security. Now, global health security is about priority zoonotic diseases. These are diseases that are transmissible from animals to humans. For instance, the COVID-19 pandemic was from animals. Important domains, if I'll use that word, that have to come together or that are implicated or involved before a priority zoonotic disease can be transmitted. That is, a disease can be transmitted from animals to man. Number one is the human being, because the human being is at the center of the triangle. Now you have the human being, you have the environment, and you have the animal. And what unites all of these three things is called One Health, to ensure that there is good coordination in animal health, that is the veterinary services, good coordination in human health, and then good coordination with the environmental health. So the human health, the environmental health, and the animal health institutions coming together is One Health. So for instance, the Minister of Health, Minister of Animal Husbandry, or Minister of Animal Health and Human Resources, and then the Minister of Environment coming together to form a committee, a One Health committee, is critical to prevent the transmission of priority zoonotic diseases. So with funding from USAID, we do priority zoonotic diseases interventions. And so as senior clinical advisor at the global level, I also ensure that the One Health interventions that we got money from USAID to implement are working well. So for instance, USAID gave us additional funding to do One Health in Nigeria, what we call global security, focusing on 4 priority zoonotic diseases. So these zoonotic diseases are rabies, Lassa fever, highly pathogenic avian influenza, and bovine tuberculosis. All these 4 priority zoonotic diseases are diseases that are transmissible from animal to man. So what the funding that USAID has given us is to ensure that we raise awareness in communities and enable them to prevent, detect, and respond to any of these 4 priority zoonotic diseases. Prevention, of course, is messaging, telling them that, look, these 4 priority zoonotic diseases exist. This and this and this and these are the things you need to do to protect your community, to protect yourself, to protect your children. That's the prevention. The response is when there's already an outbreak, to ensure that you mitigate the impact by responding quickly. For instance, if there's a dog bite, you do ring fencing, ring vaccination. You quickly get the dog, quickly test the dog, whether it's rabid or not. You quickly get the individual who has been bitten, quickly provide. So that's responding. First of all, you prevent, you detect, and then you respond. So you detect and then you respond. The response is the last part. So we build capacity along these 3 areas to ensure that we're able to support priority zoonotic disease interventions as the case may be.
Thank you so much, Dr. Samuel, for giving us, well, firstly, congratulations on this role and your promotion. It's evident that you're really passionate about the work that you do. And like you said, by God's grace, you were promoted and you were elevated to have a bigger role, to do more impact. And thank you for giving us an overview of this work that you're doing. And we really wish you all of the best now that you're not only focusing on polio, but you're also focusing on these other types of very important diseases that many people are affected by. Now, I just wanted us to go back to the polio work that you did, particularly because you said you did this for 10 years in your role, and also now at a more higher level, if I can say that. I'd like to talk about some of the challenges. You mentioned that it's a big ecosystem. There's so many people who are involved in this type of work. And the idea that, most of the work is really being done at a community level. And that's the type of, that's how you'd like to work. So what are some of the challenges that actually happen at the community level in terms of, acceptance of this, of the work that you're currently doing?
So, first of all, thank you for the warm words and warm congratulations. I really deeply appreciate it. I'll first of all start by saying that, in polio eradication, there's no high level. The promotion is basically additional responsibility for me to use the capacity I've built over the years to support countries where we work to eradicate polio and to keep the quality of interventions at the highest level. Because I still go to the communities. So I'm not sitting in the office or just, signing files and pushing folders. So having said that, the polio eradication space in Nigeria has gone through several challenges. The Global Polio Eradication Initiative began in 1988. And specifically 10 years later, in 1998, the Polio Eradication Initiative in Nigeria was born. And since the advent of polio eradication in Nigeria, one of the biggest challenges has been messaging. Myths, misconceptions have been one of the major barriers to people accepting that the oral polio vaccine is safe and that their children can ingest the vaccine without being rendered infertile or sterile. Now, some of those messages are either intentionally spread to mislead, which is disinformation, or those information are spread in a manner that they unintentionally mislead people, which is misinformation. But at the end of the day, misinformation, which is unintentional misleading of people to think that the vaccine is bad, or disinformation, intentionally misleading people, have ended up as some of the biggest challenges to the polio program. And like I mentioned before, the bulk of the cases of polio, when we began, were in the northern part of Nigeria. And because of the religious affiliation in that part of Nigeria, we needed to engage with religious leaders in the northern part of Nigeria, because when a religious leader speaks, people listen. And when he keeps quiet, people continue to do what they are doing, whether it's right or wrong. So we realize that this challenge of misinformation, disinformation, myths about the vaccine, and misconceptions that any child that is vaccinated can be sterilized or is rendered infertile was preventing mothers and caregivers from allowing their children to take the oral polio vaccine. What then happened? We're seeing a high number of polio cases. When I say polio cases, I mean children paralyzed. It's important to make this vivid, because when a child is paralyzed, you can imagine the psychological impact it has on the child, the depression, the pall of depression that falls on the family, the fact that that child cannot thrive to the highest level in which she or he is supposed to thrive in terms of what they're destined to become. So the paralysis, we're having a huge number. For instance, we're having cases as high as 100 and something cases of polio paralysis.
Sure.
A child cannot walk. So those were the challenges we had. Of course, we also had challenge of no felt need. No felt need means that, permit me to just break it down a little bit more. You come to me that you want my child to take the oral polio vaccine, but I don't have food. Even if I have food, it's not enough. So my need that I think is important to me, what I really need is food. I also need healthcare. Malaria kills, polio doesn't. So I rather that you give me insecticide-treated nets rather than polio vaccine that my child will just take. When you give me a net, I know that when I sleep under the net, my child sleeps under the net, I'm seeing something physical that is protecting my child from malaria that kills.
Mm.
I also need borehole to have pipe-borne water, potable water to drink. So the concept of no felt need came up because no felt need means that one of the biggest challenges we had at that time was no felt need. The people that we were telling about polio didn't feel the need for the oral polio vaccine, so we called it no felt need.
Mm.
The need they felt they deserved, or that was really important to them, was insecticide-treated nets, food, borehole to give potable water, education for their children. Some of them will even tell you, I need shoes. You have kids walking barefoot to school, or some of them cannot even go to school. They tell you they need schools built in their communities. They need electricity. They need boreholes. So one of the biggest challenges at that time was no felt need. I don't need this your vaccine because it doesn't do anything to me. It doesn't give me food. It doesn't give me good water. It doesn't give me intestinal treatment. So it was a big cause of vaccine hesitancy and even frank rejection. Because no felt need, I don't need it. You are giving me what you want to give me. You are not asking me what I truly need. So it was a huge problem. So communities were rejecting the vaccine en masse.
Yeah.
And in this mixture, we also had some religious leaders who were also propagating falsehood. And so, according to so and so section of the religious text, this thing is not acceptable to an adherent of the religion. So the challenge is now, how do you begin to reorient and re-educate these sets of leaders, religious leaders? How do you begin to make these communities to unlearn? In life, you learn and you unlearn.
Yeah.
To unlearn the wrong things that they learned, or to relearn things that they didn't learn properly. That gave birth to a strong emphasis on polio communication, which we call ACSM, Advocacy, Communication, Social Mobilization. So let me not go to this to that. You asked me about the challenges. So these are some of the plethora of challenges we had at that time. Misconceptions, myths, disinformation, misinformation, no felt need. And one big challenge was the fact that before we joined the Polio Eradication Initiative in Nigeria, there was no civil society involvement or engagement in polio eradication activities.
Okay.
And where people have no say, where people have contribution, where people have no voice to challenge the status quo, to say that this is how we want it, this is what we think we need, this is how we think you should give us, you can't really succeed. Especially with the background when they don't trust the vaccine. They believe that the vaccine can sterilize their children. There was no CSO involvement. And because CSO are embedded in the communities, they are from the community, they understand the local language, they understand the norms, they understand the culture, they understand all the nuances.
Yeah.
If you don't engage CSOs, you cannot penetrate the people, because the people are the CSOs. So there was complete absence of civil society organizations in polio eradication in Nigeria before CGPP came. I must at this point mention that without CSO involvement in polio eradication in Nigeria, I stand to be corrected, but I can tell you that the significant milestones achieved could not have been achieved. Even if they were achieved, it would have taken much longer, because all society organizations are from the community.
That's very true.
So, So those were the main challenges at that time at the community level. The communities didn't understand what polio was. They didn't feel the need to ask.
Thank you so much, Dr. Samuel. We've gone through a really wonderful journey of learning everything that you do. And it's been so interesting. I know for me, as well as for, I'm sure, the listeners who are going to listen to this, it was such a pleasure having you on. And also, Teresa, thank you so much for joining me today and really holding the helms of this interview with me today. It was such a pleasure.
Thank you. Thank you so much, Anne. And thank you so much, Dr. Samuel, for being here. And we've had a really, really wonderful conversation. And I must say that the story of polio eradication in Nigeria is a very good story. It's a very good story with different angles. And yes, thank you so much for being here. And thank you also, Anne, for having me as a co-host today.
Thank you. And to everybody else who's tuned in, we hope that you learned something, and we'll catch you next time. Goodbye.
Bye. Thank you.